Thank you for your time this evening, and most importantly, thank you for having the vision and commitment to be part of the PA Clinical Network. I'm Dr. John PACN, Chair and CEO of the PA Clinical Network. During our annual meeting tonight, we will reflect on our progress and achievements as a clinical network thus far, and unveil some new network products and tools to help you care for your patients. We have a busy agenda this evening and will proceed shortly. Some housekeeping items. This meeting, as you heard, is being recorded. We will have that on file for those that cannot attend. We ask that you do not make your own recording or share material of this presentation outside of our network. Our network and company are market competitors, and our material is proprietary. While we can share this information, some items are best kept within the network. Please use the chat function for any questions, and we will periodically pause and answer them. If an item requires discussion, we may ask that you accept a panelist invitation and unmute your microphone for more detailed discussion. It is often helpful to go back to the beginning and acknowledge the Pennsylvania Medical Society and their prescient vision that became our network. Over a decade ago, our PA-made House of Delegates recognized the commitment and that was necessary for the coming payment paradigm shift in healthcare, and knew that our physicians would need to get in the game and lead that transformation. Years later, the PA Med House of Delegates once again committed resources to the Practice Options Initiative that strives to reserve a choice for our doctors on how best they wish to practice and care for their patients. For some, they may want to work in a hospital setting, but for the courageous and independent that want to care for their patients the way that is best for their population, the PA Clinical Network will help those practices to not only survive, but to thrive. And remember, a rising tide floats all boats. Even physicians in employed settings are well served by knowing that there is another option to how and where you can practice, especially when contract renegotiations occur. One of the very special aspects of the PA Clinical Network is our unique history and our origin as a sole dedication to you, our members. As a brainchild and subsidiary of the Pennsylvania Medical Society, our governance is centered around you, our doctors. It is not top-down or administratively dictated by a hospital, insurance payer, or Wall Street venture capitalist. This is a physician-led network and run by you and your input on our boards and committees that make it happen. We will hear in more detail tonight about our key committees and their work. And please consider joining a committee if you want to get more involved. Your time is greatly appreciated and it is compensated. Although the PA Clinical Network is relatively new, we have a critical mass of excellent doctors and patients to move the needle. As you will hear later tonight, we have quality performance recognition arrangements with 7 commercial payers, as well as CMS in our first year as an ACO. We are in all regions of the state and growing. We have certainly come far from the vision of PA Med now, with almost 70,000 covered lives, 65 practices, and almost 200 physicians and providers in our network. And we are the only clinical network wholly sponsored by a state medical society. Many thanks to you for bringing this bold vision to life and the achievements that we have made in just a couple short years. Realize that very few networks get to the point of returning money back to their doctors. This is only the beginning. As you enjoy our program tonight, enter questions into the chat as needed, and we will circle back to them. We have a rich agenda where you will hear from our talented management team of Bruce Rocher, our COO, to review financial achievements, Wendy York, our Senior Quality Director, to go over network and practice performance, and Keith Taylor, Senior Director of Business Development, to go over the unique partnerships that PACN offers. We will also hear from some of those partners tonight. Curie will go over the recent unfortunate PA Supreme Court venue ruling and how that will impact your practice and medical liability insurance, as well as review important services they also have for your life as a physician. Complex care management will be addressed by Brilliant Care and also our behavioral health tool, Mindula. Lastly, we look forward to the future and beyond with our network and ACO and answer any questions. Our COO, Bruce Rocher, will come forward now with some favorable network updates. Bruce?
Thank you, Dr. Pradhan. Good evening. Again, my name is Bruce Rocher, the Chief Operations Officer for the PA Clinical Network. And I'm here to review the recent distributions distributions that have come out since the beginning in 2020 as of August 31st. But first, I want to recognize our Funds Flow Committee, chaired by Dr. Paul Williams. And this committee is very active. We meet mostly every month, and they review the information that we receive from payers and the allocations that go to the member practices. The way it normally goes is that monies are deposited into our account, and then the information regarding those monies comes just a bit later. And then I do the modeling for the distribution to the practices, and then we bring it to the Funds Flow Committee for their review, for their comments, for any changes that they see fit. And then once approved, we then, it goes to accounting, which is me, and we then distribute it to the practices as quickly as possible, either by check or by ACH. The Funds Flow Committee has developed its rules regarding the monies that are distributed to the practices. In 2020, we started out with a 50% participation allocation if you participate in the network, and then a 50% performance allocation based on the quality measures and the quality metrics that were achieved. In 2021 and 2022, the committee decided to move to a 25% participation and a 75% performance allocation. And just as an aside, if you joined the PACN, let's say in 2022 or 2021, your first year in the network, any monies that come to you would be 50-50, and then you would go to 25-75. Each payer is very unique in the information they provide to us in order to distribute it to the practices. Sometimes it takes more time for them to get the information to us. Sometimes the information is very clear and it's very easy to get to the Funds Flow Committee. Other times, our management team has to work hard to develop the allocations and the protocols in order to get to the Funds Flow Committee. Coming up should be before the end of September. Each practice will receive their own personalized list of what they have received since inception into the network through August 31st. And then when you get that, of course, if there are any questions, please don't hesitate to reach out to me. Right now, the Funds Flow Committee has not determined what the allocation will be for 2023, but that will occur probably over the next several months. And finally, I just wanted to show you where we're at here with distributions to the practices through August 31st. Just as a look back, a year ago when we had this meeting, this slide showed distributions of approximately $170,000. So we have, as Dr. Pradhan likes to say, we've added a zero at the very end. And so right now, through August 31st, we have distributed close to 1.7 million. Over the next 2 months, the Funds Flow Committee will be reviewing distributions to be allocated to the practices of almost $300,000. So in the next month or so, we will be approaching $2 million of distributions from these payer contracts to our practices. And we hope that it actually goes over 2 million before the end of 2022. Again, if you have any questions, always reach out to me. And now I'd like to introduce Wendy York, our Senior Director for Quality. Wendy.
Thank you, Bruce. I'd like to start out by acknowledging our quality improvement committee before we start the quality segment, chaired by Dr. Alok Malankar for their dedication and commitment. This committee discusses and reviews health plan scorecards, practice scorecards, and we look at areas of performance, areas that are identified as potential improvement opportunities. We suggest ideas or suggest critical guidance is offered of improving workflows and processes and overall quality and improving overall quality performance. This next slide looks very busy. These are our value-based contracts and basically the results of what you're seeing here. There's a lot of green check marks here, which is good. We fell short in only one value-based contract, which was Gateway. But starting with Aetna, we have over 4,000 Aetna members, and we achieved a 4-star rating in 5 of 15 measures, and our overall star rating was a 3.26. And that again is our Medicare line of business. Capital, we had over 8,600 members for 2021. We achieved a gold level star performance, and we had a gap in care closure payment for Medicare line of business for those measures. Geisinger is a little complicated. We have over 8,800 members, and we have a PQS program, which the practices participate in, and the practices are paid based on their own individual performance. This money is just passed through to them, but our quality team is working hard to still close those care gaps and help the practices in their quality endeavors for the Geisinger program. We also have in that program Geisinger Gold, which was a new program for 2021. And there's over 2,600 members in that program. And we achieved target in 5 incentive measures for Geisinger. And payment is, as you saw, is going to be distributed shortly from Bruce's presentation. Highmark, we have broken into 3 regions. As you can see here, there's over 37 or 30,000 patients between all 3 regions. And we're in a True Performance Plus program, and we hit the lump sum quality threshold in all 3 regions. Central PA was 74%. Northeast PA was 83%, and Western PA was 84%. Our goal for quality, for the quality gate is 50%. So we exceeded that, hugely exceeded that. We did fall short in cost and utilization. Some of this is based on hospitalizations or readmissions and ED utilization. Highmark Whole Care, formerly Gateway, we had 2,400 members, and it's a shared savings program. We needed to hit 60% of our measures. We fell short. We hit just under 50% of our measures. So we did not hit the target for any gain share for Highmark Whole Care. Highmark Whole Care also has a practitioner excellence program, which is a separate revenue stream. And we did attain that. That's based on previous year's performance, 3, 5, or 7% improvement over what we did last year. And we only have to have 10 members in the denominator, which it makes it a little bit more easy to achieve, since the Highmark Whole Care Gateway Shared Savings Program, we need 30. Humana, we have over 1,000 members in that for 2021. This is our model practice. We achieved 4 or 5 stars in 12 out of 16 measures, with an overall star rating of 4.04. UPMC, we have over 11,000 members, and we achieved 1 or 2 tiers in target in 6 incentive measures across 4 lines of business. Those measures were controlling blood pressure, hemoglobin A1C, and overall Medicare gap closure. We hit the star target level for that, which was 3.8. Challenging measures across all lines of business were breast cancer screening, colorectal screening, and diabetic retinal eye exam, and chlamydia. I want to, at this point, tell you about some measure updates for 2023. The kidney health evaluation, the KED measure, is replacing the nephropathy measure. It is profiled this year, but it will be scored in 2023. And also colorectal cancer screening, the age has been lowered to 45. And information has been and will be forthcoming from your quality directors and clinical transformation consultant. And for any questions and further guidance, you certainly can reach out to them. I wanted to take a moment to acknowledge our top performing practices for 2021, and 8 practices scored in the top 10 or 12 in 3 or 4 value-based contracts. We understand that not all practices participate in 4 or 5 different lines of business or value-based contracts, so it might be a little tougher for them to achieve this, and you might not be recognized here and you might still be doing good quality. But I just want to acknowledge these practices for 2021. And so who you're seeing here is Family Medical Care of Lawrence County, Miller Dunmoyer Health Center, Family Health Center in Shamokin, My Care Now in Du Bois, and Dr. Ramanian from Wyomissing, Open Arms Internal Medicine and Pediatrics from Williamsport, Pleasant Valley Family Medicine from Lock Haven, Sudhir Khanna in Shamokin, Warda Medical Center in Cole Township. Again, this is another busy slide, but this is not all-inclusive list, but captures main activities that's been the focus of the quality team this year. First off, when we start the year, the clinical practice guidelines have to be reviewed and approved each January. So that's the first thing that we did this year. The quality committee does review the guidelines, and these are based on evidence from multiple professional organizations such as NIH, CDC, American Academy of Pediatrics, and the American College of Cardiology, and others. Also would like to acknowledge this year we expanded our quality team and we added Janelle Arthrell, clinical transformation consultant, and she's the newest addition to a quality team and began in January. She comes to us from Aetna, where she serves as a HEDIS outreach coordinator. She has also experience in billing and coding and is responsible for servicing the practices in the western part of the state. The team consistently works on care gap closures for the value-based contracts, and that's pretty much their daily and ongoing focus. They do have access to 21 practices' electronic health records, which further assists in data mining and gaining insight to practice workflows and processes. They analyze and reconcile payer gap list and develop strategies customized for each practice in a focused approach. We also identify ED utilization. If there's any areas to reduce costs for 90-day prescribing, and working with the health plan pharmacists, recognizing lower cost alternatives and deprescribing when and if possible. We also completed a patient satisfaction survey, again, for the 2nd year in a row for Capital Blue Cross. Again, this was a criteria of our value-based contract with Capital. It was a 15-question scoring that was a 1 to 5, very poor to very good. The practices receive their scores. Practices will be receiving scores shortly. We just finished this. It was done with a QR code this year, so it was done all electronic. We didn't have any paper surveys this year. 7 practices participated, and we had 85 completed return surveys from practices. We'd like to thank all the practices that did participate, and we'd like to acknowledge Dr. John Manubay's practice in Wyomissing, Sinking Spring. Sorry about that, Dr. Manubay, and Lynn Bradford for having the highest number of return surveys for their practice. We also worked on practice action steps with the Quality Improvement Committee for any impact practices, and that will be reviewed monthly, ensuring practices are moving in the right direction for moving the quality needle. We also work with credentialing and re-credentialing, reviewing documents from the CAQH website. That's the Council for Affordable Quality Care, which includes any past claim histories and any kind of education and background on each of the physicians. We're also review and analyze previous year's performance, which we are currently working on now. And the team yearly updates annual playbooks and tip sheets that have edits that need to be made yearly. Practice scorecards are developed too, based on health plan information, so that we can look and see how practices are performing and ranked, how they are ranked against each other with the other PACN practices. I'd like to also mention that our member website houses our tip sheets and our various quality resource materials that can assist your practice in care gap closures, improving your quality scores. We develop, research, and supply clinical information to the Quality Improvement Committee and also the Credentialing Committee. And I have acknowledged that, I already have the slide up. At this time, I'd like to acknowledge and thank the members of the Credentialing Committee, chaired by Nada Rahmanian, for their hard work and dedication. They review patient practice physician information based on claims. Each clinician, we look at claims, really look if they have an accurate and up-to-date license, DEA license, medical liability coverage, professional work history, and education and training. The committee reviews this information on an ongoing basis. They have so far to date newly credentialed 231 clinicians and re-credentialed 124. Slide is not advancing. At this time, I'd like to acknowledge the high-performing practices so far for 2022 and their claims paid through July. These practices were the top performing practice by health plan. We only have 5 payers that supply us this information, so I do not have Gateway and or Capital listed here, but you can see the top 5 in each category based on overall performance year to date, and that's through July 31st. So again, there's plenty of time. If you don't see your name listed here, there's plenty of time to move that quality needle in the right direction. Next, I'd like to talk a little bit about our website. If you haven't visited it, there are plenty of great resources at your fingertips. This is a screenshot of what you see when you log in for the first time for the members, from the members button. This is the members landing page that you'll see with practice information along with your practice tiering level. And the next slide here, you're seeing a practice ranking and your attribution. There's a slide that lists care gaps and how many are remaining. There's also a slide that shows star performance month over month. And this final slide shows where you can tab and get to the resource guides along with many helpful tip sheets, the quality team completed and created to assist you in your practice workflows and quality measure guidance. This is constantly being updated and enhanced. And finally, some keys for success. You've all heard about the pre-visit planning and how important this is. That ensures that when you see your patients, the office visit is as efficient and productive as possible. Also, annual wellness visits is very important. Getting your patients in early in the year so that the patient, you can ensure that the patient's tests and routine studies are being done throughout the year. By year's end, that you are revalidating any diagnosis codes that may be missing from the prior year. CPT2 coding, these are pseudocodes that do not carry a dollar amount, but are critical in reporting that the service was done or reports that the results of the service to satisfy the measure. Risk coding accuracy, again, another huge importance. Ensures that you're coding at the highest level of specificity, include any complications when appropriate, and chronic conditions must be revalidated and recoded every year or they'll fall off and your risk scores for your patients and your population would be reduced. Reducing ER utilization and readmissions. This is always a tough one. I know there are some of your patients that are sick and they need to utilize the hospital and the emergency room. Sometimes it's difficult to deter patients in accessing the ER for avoidable conditions. And if we reach out to you regarding a report from a payer, we're merely passing this information to you, this information so that you are aware. Sometimes there's nothing more that can be done, but we just are making you aware. As always, again, visit our website for value information and resources to assist your practice with quality efforts. And as always, please reach out to your quality director or clinical transformation consultant for more information on any quality guidance that you may require. Thank you. And again, now I'll turn it over to Dr. PACN.
Thank you, Wendy, and thank you for the hard work that your quality committee and team does all year long. That is indeed the driver of all of our success. Next, we'll hear from one of our network partners, Curie. Jason Newton is general counsel at Curie, a physician-focused medical liability company out of North Carolina. Jason will review the new Pennsylvania Supreme Court venue ruling and how that will affect our practices. Welcome, Jason.
Muted.
Thank you. Can you hear me?
Yes, we can. Thank you.
Okay, great. And I wanted to share my screen here as well.
Yep, I think we're doing that right now.
You should be able to share.
All right.
Should be good to go.
Okay.
Yep.
All right. Can you see the presentation view? Okay,
Yes.
great. All right. Well, thank you so much. As was mentioned, I'm Jason Newton, General Counsel of Curie, and wanted just to share with you our advocacy efforts in Pennsylvania, which really are consistent with the way we approach advocacy in any jurisdiction in which we have a significant presence of physicians who are not only our insurers, but our members, our owners of our company. And since we joined the market in Pennsylvania since 2016 in a very significant way, we've been looking for partners so that we could offer our sweat and equity around advocacy efforts and issues that touch independently practicing physicians. And Pennsylvania Medical Society has been a big part of that. Pennsylvania Coalition for Civil Justice Reform and many other stakeholders that are too numerous to mention. But I think the topic that it's on everybody's mind is as was mentioned, venue reform and the August 25th order that the Pennsylvania Supreme Court issued that essentially overturned approximately 20 years of venue stability, at least. You know, Pennsylvania does have its challenges in terms of venues and what we call severity, dollar amounts of awards, and judges that tilt plaintiff as a general litigation environment. But venue reform was meaningful, as I'm sure many of you lived through and remember, in terms of its effect on the what I've called here medical professional liability exodus out of Philadelphia. And how did we get here? You know, back under the cover of the holidays in December of 2018, it was a relatively obscure committee called the Pennsylvania Supreme Court Civil Procedural Rules Committee that shortly before that had become significantly imbalanced in plaintiffs' attorneys' favor. And that resulted in the public indication that the venue reform provision that had been on the books via this rule for 20 years was now in jeopardy. And so what happened was relatively quickly that we jumped in with other stakeholders to fund a study by the nationally recognized and respected actuarial firm Milliman that demonstrated that if venue reform in Pennsylvania went away, there would be a significant impact, at least as it relates to insurance premiums, medical malpractice insurance premiums for physicians around the state, impacting, for the most part, those that are in specialties that are higher severity. You can think about, you know, OBGYNs, neurosurgeons, and orthopedists, but also those that are lower severity and also those that are in lower severity venues. So it would affect everybody in Pennsylvania, is what Milliman said. And we reached out to all of our members, all of our physicians and APPs and practice administrators to encourage grassroots efforts to legislators in order to study this issue rather than let this committee for the Pennsylvania Supreme Court that was appearing to now go rogue to call them into check, if you will. We also did a number of things sort of on the grassroots level, on the, you know, in the trenches level. We had at one of the press conferences around this at the Rotunda at the state capitol, we had a delegation from our Camp Hill office go and attend that press conference to sort of kick off bringing sunshine around this proposal that the Supreme Court committee was suggesting. Our VP of underwriting also appeared on a recorded segment that was played on a cable news network to talk about what the impact on physicians in Pennsylvania would be. We had a claims examiner attend a public hearing in Harrisburg that involved legislators. We drafted letters to the committee's counsel asking them to study the issue further. And you know, we got an indication of good news back in February of 2019, where the effort to overturn venue reform was stalled in order to allow further study. And then we also began encouraging defense counsel, that is the defense attorneys around the state that do work for our insurers when they are sued in medical malpractice cases. We encourage them to get involved in throwing their hats in the ring to become members of committees like this committee, so that things like this hopefully would not surface as frequently and as severely as they did this time around. In any event, more work was needed by Milliman, and we and other stakeholders helped fund that. And then the pandemic happened and the rule change issue sort of stalled, like so many other things. And the focus in early 2022 became whether the Senate Judiciary Committee would find legislative partners to engage in independent actuarial study. That's not one hired by stakeholders, but one actually hired by the legislature to determine what the effect on physicians would be. And we then rekindled our grassroots efforts with our members, asking them to email the Senate Judiciary Committee. And then as of March, things began to look dismal, and the Rules Committee shut down in terms of any transparency in terms of what was happening there. No stakeholders in the Commonwealth could determine what the future of the rule would be, but the signal was ominous, let's put it that way. And so the strategic focus shifted to a constitutional amendment, which would have been affected by a bill introduced in the House. And again, we focused on grassroots efforts, and what would have occurred was a constitutional amendment that would have held the Supreme Court in check if that had been successful. Around the same time, purely coincidentally, the Senate Judiciary Committee got its actuarial study back. It was again commissioned through an independent firm, Oliver Wyman, and the predictions there were similar to what Milliman had said. And I'm not going to read you here what the projections were in terms of likely increased premium rates for hospitals and physicians, but you can see that in most places they're the double digits. And so again, not looking good in terms of what might happen with premium. So we put our foot on the gas and emailed all the House Judiciary Committee members from Curie directly. We had our members outreach again through a grassroots campaign, did an outreach a third time in June, a fourth time in June, and time was running out, and there were other issues and crises around the country, including mass shooting incidents that were taking the legislature's eye off of the venue ball. And ultimately what happened is that the session stalled without any action on venue reform. As a result, the earliest that any constitutional amendment could legislatively be effective is in 2025. And it's interesting because we had a meeting with the leadership of your group in Raleigh on August 23rd, and we sort of questioned whether mission had been accomplished because we had no order from the Pennsylvania Supreme Court, which is all it would take to overturn 20 years of venue reform. And then 2 days later, we were jinxed and that order came. So what's likely to happen now? Well, the old rules, that is the rules that were in effect before 2002, are coming back effective for cases filed on or after January 1st of 2023. We believe that plaintiffs' lawyers are likely to hold off on filing new actions before January 1st unless they face a statute of limitations issue because they want to take advantage of more favorable access to venues, which they will have after January 1st, barring anything else happening. We think there'll be more medical malpractice suits that are filed and more that are filed in the bad venues. And now medical malpractice actions are subject to the same more liberal venue standards that apply to all other types of civil cases, including where a defendant may be served. And so if you think about the practical application of that, all the care may have taken place in Chester County, but if one of the doctors or a resident who was involved in that care, 2 years later, when the plaintiff's attorney is looking to file suit, if one of those care providers had moved into central Philadelphia, that in and of itself, even though no care took place there in Philadelphia, could provide and likely would provide access to the plaintiff's attorney to file suit in Philadelphia. So we're exploring strategies that might be alternatives to a constitutional amendment with other stakeholders, and also considering risk advice, if you will, for how you may intake patients and forms that you might ask them to sign as it relates to venue selection and mandatory arbitration. But all indications are that courts would not look fondly upon that. And so it appears that venue reform is going to be done as of January 1st for the time being. In addition to our work on venue reform, we try to be involved in a number of other issues, and I'll just make you aware of a few. I serve on the Pennsylvania Coalition for Civil Justice Reform's Attorney Advisory Committee, and as a result, we get involved in amicus or friend of the court briefs that are sometimes successful, sometimes not. And in all of these instances, don't involve cases that have our insureds as defendants. And so sometimes we pay money. Sometimes we get the benefit of being a member of the Pennsylvania Coalition for Civil Justice Reform. Sometimes we have our name on the brief. Sometimes we don't for strategic reasons. But there have been some significant wins as a result of that activity, including the Mitchell versus Shakura case, which involved informed consent being an issue at trial. So there's a number of opportunities that we've been engaged in, and there are a number we're considering actually right now, including one that is an attempt to erode the felony conviction rule in Pennsylvania. That is to say, if someone commits a crime and they want to blame their healthcare providers, essentially their theory is they should be entitled to potentially an award if they can prove malpractice by their provider. and we're likely to be involved in opposing that. I also just want to put one thing on your radar. Chief Justice Max Baer is going to retire from the Pennsylvania Supreme Court at the end of this year. And so we are entertaining and committing to financial contributions to a PAC to support what will be the first in a while competitive race for a newly vacant seat on the Pennsylvania Supreme Court. And that election again will occur in 2023. So those are some of the issues that we've been working on, and an update on the status of venue reform. Unless there's any questions, at this point, I'll turn it over to my other colleagues.
Thanks, Jason, for that sobering update and for your insights. And we look forward to actionable strategies from PAMed, PACN, and key stakeholders such as yourself. I would also say that being a member of PAMPAC, Jason spoke of the upcoming Supreme Court candidacy and justice, that physicians have to get in that race. We have to be part of the solution. In addition to your membership to the Medical Society and of course, our network, being part of the PAMPAC or our PAC is important, as Jason said, to look at those candidates and get judges with common sense onto the Supreme Court.
Let's go back one slide to defending good medicine. Let me share some thoughts. First of all, to all my physician sisters and brothers, thank you for the honor to participate in this general meeting. I participated right from the login, and I will tell you, I am impressed. I am humbled by the dedication in this group. One of the earlier slides said it is imperative that physicians have direct input. And it was apparent to me from the commencement of this meeting that after the patient's needs are met, then within this group, the focus is you, the physician. This directly aligns with Curie's focus. And I apologize that the technological gremlins that we face caused Gabe to fade in and out, but I'd like to sort of pick up where he left off. I believe he indicated to you that Curie was born out of really a crisis in 1975. The North Carolina Medical Society sat physicians down in a room and said, there is a problem because you need some insurance paper in order to see patients. And we literally, my predecessors literally passed the hat. And with the Medical Society, Medical Mutual was born and more recently changed to Curie. It's good that this slide is visible to all because Curie exists to serve its members. And as Gabe said, 1,500 are in your state. We have a total of about 14,000 physicians who subscribe to our malpractice paper, and about 12,300 of those own the company. I work for them. My boss, Jason Sandner, charged me every day to wake up and ask, is what I'm doing going to help our doctors in medicine, business, and life? If so, continue. If not, stop. We will defend good medicine through Curie Insurance to the hilt. We all know that between 8 and 9 of malpractice cases that are filed are really nothing like true malpractice. They are bad disease, but not bad medicine. We are proud at Curie that because of our diamond defense teams and the tenacity of the whole claims department, we have a 79% win-loss success ratio. That is higher than the industry average. You will see other figures there that talk about claims and suits closed with a payment. Curie's number is 11%. The industry average is 30%. I will also proudly say, in defense of good medicine, that we proudly spend more money to send our attorneys to bat for our doctors than we do in indemnity. Next slide, Keith, please. Curie was born in medical malpractice, but now we have broadened to become a full-service physician advisory. Within our advice, we have a dedicated risk department. They blend seamlessly within both the insurance and the advisory arms of our company. On the slide, there is basically a summary of what our 1,500 physicians in Pennsylvania have available to them at any time. And they always have a risk advisor available either through email or with a call. Next slide, please. Our coverage is tailored to your needs. It's not about us. We take our expertise that this was created by physicians for physicians, and it's about you. I want you to rest easy knowing that you're getting the best expertise. I don't want to dwell on the line items out of recognition for the busyness of your agenda. Keith, next slide, please. We have a second arm of Curie, which is the advisory arm. Basically, understand that we have a very powerful analytics platform, which is a superb suite of software that will plug into your individual practice. It will generate on a daily basis items to tell you about usage of key performance indicators and also enhance your online reputation management. Just want to check because there's a couple of tech gremlin rattles. Are you still hearing and following my speech okay, team?
Yes, you're good.
Thank you. The other part of Curie Advisory is our consulting services. We have amassed a team of just medical experts, practice managers, coding, compliance folks who basically pool their brains to consult for services that you and your practice decide are important to you. We don't offer a proscribed list of services. You tell us what we need, we tweak that to your needs. Next slide, please. Curie has performed well. We are proud of that. Our members demand nothing less. We are stewards of their money. And about 5 or 6 years ago, some of our physicians said, wow, you perform so well. Can we benefit more directly from your performance? We said, of course, you own the company. At that point, Medical Mutual decided to think, what can we do differently for our owners? And as well as changing the name, what we did was form Curie Capital with a 3-pronged goal. Number one, allow our physicians to participate with our financial expertise in either their own wealth management or their retirement plan solutions. And then also any physician, any lawyer, any architect who wants to bring a certain amount of cash into Curie Capital to benefit from our expertise can do so by a whole suite of public, private, and other alternative investment strategies. So again, Curie is a 3-legged stool built on insurance, now with a capital arm, an advisory arm, and it strikes me that given the passion in your organization, there is so much synergy. It's been a high professional honor for me to meet John and Keith, and I again want to thank you all for your dedication to your patients, your support of each other, and your willingness to look in the shop window of Curie. It's my pleasure to serve. Thank you.
Well, thank you very much, Curie. Again, I'm sorry for the technical difficulties that we had there for a little bit. We will entertain any questions for Curie at this time. Again, if you can put them in the chat, that would be great. And if not, we'll move on. There again, if you think of other questions going forward, we can address them individually. Do we have anything related to Curie in the chat? Again, we were running some tests on the chat a little bit earlier. I'm not sure if you could see them. They had nothing to do with this event if you look at the timestamp there. So again, we'll move forward there, and I'm going to introduce Keith Taylor, our Senior Director for Business Development, who's going to talk about some of our other strategic partners in the network.
Thank you, Dr. Pagan. Good evening, everyone. My name is Keith Taylor. I'm the Senior Director of Business Development for the PA Clinical Network. One of my roles is to explore and vet partnerships that can be beneficial to you, your practice, and hopefully the network as a whole. And sometimes these come in the form of discounts or discounts on items you might consider cost items, such as medical professional liability insurance, credentialing, or maybe HIPAA verification. Other times, it's finding a service that we can help to promote that might help improve quality, while maybe even providing some increase in fee-for-service revenue to your practice, such as care management or behavioral health, both of which you will hear more from a little later this evening. But in that role, I rely very heavily on the GPO subcommittee. I'd like to acknowledge and thank the people that you see on this screen, particularly the chair, Dr. Jack Armstrong, but also the others, and not just for their valuable insight, but also for their time commitment that they put forward on this committee on behalf of all of the PACN members. So thank you very much to the GPO subcommittee. With this next slide, what I'd like to do is acknowledge and recognize some of the current partners that the PACN is partnered with on your behalf. And I'll just go through several of them on this slide. The first one being LabCorp. We've been communicating with the LabCorp for quite some time now. And what we have learned is it really does make sense geographically within the state of Pennsylvania for some of our practices to consider LabCorp, those that are not. They have a lot of care centers throughout the state. And aside from the obvious lab services, they also have good patient outreach that can help your orders get carried through by the patient. So they do some good patient outreach as well. So I just ask or encourage you, if you get that email that has a LabCorp on it, or somebody's passing a business card through in the waiting room, asking for a few minutes of your time, I would encourage you to give it to them. In particular, you'll probably see the name of Jack Muller come through. I just ask for you to give them a few minutes. Brilliant Care is a care management organization that utilizes remote patient monitoring. You'll hear from them in a few minutes. Mindola is a behavioral health organization. You will also hear from them shortly. Risk Strategies is a broker that the PACN has been working with for several years now. They've helped with the NorCal discount during the inception of this organization and have been an integral part with Curie recently, and will be helping with any transitions over to Curie. Incept is our marketing partner. Curie, who you've already heard from. Abbott does molecular point of care screening at your office. Health EC, probably one of the original partners, the population health platform that we work hard to plug into your data and the electronic health record systems to ensure proper data analytics. Henry Schein, which is not a stranger to everyone. We know them as a distributor, but we also utilize Henry Schein as a good networker. They have introduced us to many of the people that you see on this slide, or many of the organizations that you see on this slide, to help us find services for our members. MedEnt, electronic health record company. Although as a PACN, we don't mandate that all practices be on the same EHR, we do work well in the sandbox with many of them, but MedEnt in particular has been very good to our members. And as some practices look for their first EHR system, or others are looking to switch, we do encourage and promote MedEnt. Catalyst Consulting is a coding and credentialing company that provides specific unique discounts just to PACN members in the area of credentialing new clinicians to your practice, as well as some coding education as well. I'm sorry. Let me get my slides working too. Yeah, I might need you to advance a slide, Dr. Pagan.
Okay.
Just hit the down arrow.
Got it?
Yep, MAD Technologies does HIPAA verification. And I think I have control now. And NorCal, which many of you already have taken advantage of for some of their liability insurance discounts in past years. So all of these organizations can be found on the PACN website. You can go to the Partners tab after you log into the member side, click on their logo. There'll be a brief form just asking you for a name and an email address. That information would come to me. I can then reach out to you. I'm happy to make a personal introduction to any of these organizations, any of these partners, and walk you through the process and walk through the process with you. We continue to explore other areas as well. All right, Dr. Pagan, I'm gonna have to rely on you again. Down arrow. Other areas that we continue to look at, Exact Science, which is the parent company for Cologuard, obviously for cancer screenings. Quidel is a antigen point of care screening company. Oh, let's go back. There it is. Oh, I think I got it. Holter monitoring, we continue to look at. Stellar Health, we've been in constant communications with. They're a staff incentive program. We also are looking at ways to help with diabetic retinal eye exams, which are always an integral part of quality. So we've talked to a couple companies there. And Talent Care, which is an ongoing issue throughout the state, not just in the CAN, but staff recruitment and keeping people working in your office is a challenge. And we recognize it, and it's a tough one to solve, but we do look into that. I would ask that everyone follow your PACN, whatever social networking platform you, your spouse, your kids, your grandkids, whoever it is, whatever they're using, LinkedIn, Twitter, Facebook, Instagram, go on and search for at PA Clinical and follow us there. So I'd mentioned that you'd be hearing from a couple of these organizations this evening. And as you might imagine, many organizations contact us, but not all of them are a good fit. For example, most of them have a great product, but do they fit into the PACN philosophy? Can they adapt to the uniqueness of independent practices? And what is the cost, not just in terms of dollars, but also in terms of workload and time? So a question we always ask vendors that want to work with us is, how easy is it for the physician? They oftentimes make it easy for the patient, but how easy is it for the physician, the nurse, the MA, the front staff? How big of a burden could this be on the practice? So these next two organizations that I'm going to introduce you to, they check all of these boxes. So I'd like to introduce them individually, just give them a few minutes to introduce themselves and what it is they do. The first one is Brilliant Care. Brilliant Care uses remote patient monitoring as a tool, but they truly are much more of a care management and patient engagement company. They take on the heavy lifting. Currently, we have one PACN member practice who has already referred up to 80 patients into this program, and they're very happy with it. And we look forward to getting more practices on board as well. So it's my pleasure to introduce Alicia Thornton of Brilliant Care, who's going to walk through just a few slides with us. So Alicia, it's all yours.
Thank you, Keith. Are you able to hear me okay?
Yes.
Perfect. Thank you all so much for allowing me to join your meeting this evening. Oh, I think we lost the slides. What I will be presenting this evening is really a brief overview of who Brilliant Care is and what we do. And then if anyone is interested in learning more, going through the details, you can contact Keith directly, or you can reach out to me. I do have my email address on the final slide of my presentation, and would be happy to take you through some of this information in a one-on-one setting. But basically, Brilliant Care is a population health management company with the objective to substantially improve health outcomes of at-risk patients, while also minimizing unnecessary ER visits and hospitalizations. So really, in a nutshell, that's what we stay focused on. But what's nice is that we align with the care centers that we work with, not to enroll all patients, but to enroll the right patients onto the program. And namely, that's uncontrolled hypertensive, diabetic, or heart failure patients, or those patients who are high ER utilizers and high, frequent flyers of the hospital, if you will, sometimes in the form of COPD or CKD patients. In addition to improving patient outcomes, our goals are also to help practices improve quality scores, and then to just reduce the overall total cost of care. Next slide, please. So the way that we're able to achieve this is really through two things: increased nurse access and timely triage. So we provide patients with direct daily access to a dedicated nurse from our team who works as an extension of the provider and the care teams that we partner with. Our nurses use a very high touch care approach that's then integrated back into the practice's existing workflow. It's always the same nurse working with the same patients and the same practice. So it helps to create that continuity of care and really provide an additional nurse, again, to work as an extender of the provider. RPM is just one piece of the program, as Keith mentioned. It is how we ensure timely triage, but also as a bonus, it does provide some fee for service revenue for the practice, which ends up being about $50 per patient per month, if you kind of break down the finances. Next slide, please. So clinically, we are seeing really great outcomes with the program. So 86% of patients have shown clinically meaningful improvements in their health in just 24 weeks. 1 in 2 patients have come under control. And if you can see there in that top line, in the highest risk group, patients who started the program with a systolic pressure of 160 or greater, we have an average reduction of their systolic pressure of 27 millimeters of mercury. So clinically, we're very pleased with what we're seeing. And actually, the longer that patients continue to remain on the program, the greater that percent of improvement and the greater percent of controlled continue to be. Next slide, please. Oh, sorry, there was some animation in there. So the way that we're able to achieve that as well is by keeping our nurses hyper focused on 2 things. And it seems like some of the text may be messed up a little bit on this slide, but basically our nurses stay focused on daily compliance and medication adherence. So working with patients to coach them to make this program part of their daily routine, to get in the habit of taking a reading every day, that in turn gets the patient more compliance with medication and taking their medication every day. So that's how we're able to improve health outcomes. And then we're able to prevent unnecessary ER visits and hospitalizations because we get the readings in real time. We're able to triage the patient in real time, assess their symptoms, and then really direct them on what is the best point of care. Sometimes it is to go to the ER or the hospital, but oftentimes it's not. And so our team is able to intercept those patients and prevent those unnecessary visits. Next slide, please. So CMS says any patient with at least 1 chronic condition is eligible for the program. But what we do is we work very closely with the providers and the practices that we partner with to customize the program to focus specifically on those at-risk patients that they deem appropriate, that they want to, get better control over. And so we can really tailor the program to look at, specific hypertension, diabetes, or heart failure. Next slide, please. So generally, programs like this, they can be very complicated. So as you can see on this screen, there's a lot of parts and pieces to the program. We have worked very, very hard to keep it simple, to make it easy not only for providers and their care teams, but also for patients as well. So there are 4 parts to the program. There's ordering, monitoring, triage and escalation, and a few administrative items. So I'll just quickly walk you through what the 4 parts are. But basically, with the exception of placing the referral and submitting for billing, our team does everything else. We try to do all of the heavy lifting and really, not put any additional work on the provider or their teams. Next slide, please. So we understand, as providers, you're very busy, your staff is very busy. So what we do is we actually go in and help you identify who are the patients who would be good candidates for the program. We remind you directly at the point of care by plugging notes directly into your EHR so that you're able to see which patients would be a good candidate. We've simplified the referral process so that it's all done within the EHR that you're used to working within. In some cases, it's a single click to send a referral over to us. We also provide every care center with patient education cards that can be put in each of the exam rooms so that as the provider, as you're mentioning to the patient, it helps to make that process very easy. You can hand them a card, let them know you're recommending them to us. Once we receive that referral, we are going to outreach to the patient, educate the patient on all details of the program, ship them their device directly, and then we begin the monitoring with them. Next slide, please. We currently have 3 devices available. They are all FDA 510(k) notified. There's a blood pressure monitor, a blood glucose monitor, and a weighing scale. We do have pulse oximeter coming soon. With the glucometer, one important thing I'll mention there is that we provide the lancets and the test strips, and we replenish those as needed at no additional cost to the patient. So for diabetic patients, that's a great value add that they would know they wouldn't have to pay out of pocket for those. Next slide, please. And because this is a Medicare program, we've worked really hard to make sure that we've identified devices that are senior friendly. So all of our devices are cellular enabled. They do not require a smartphone or Wi-Fi. The patient doesn't need to log into anything or to remember any passwords or connect the device to anything. So literally they're pre-configured, ready to use out of the box, which is critical with this population of patients. So patients, they have expressed, the simplicity of our technology, which is great. Next slide, please. What's not simple is our monitoring. So our nurses are really there to do so much more than just track vitals. So they're trained to use a very high touch care approach to form a bond, a relationship with the patient, and really help to keep patients compliant. Again, not only with their readings, but also with taking their medication as prescribed. They're there to also educate patients on other areas of health and wellness, on their disease, on things like diet and lifestyle, and then also to help reinforce anything that the provider may have specifically in place for that patient. And then our team is the first point of contact to triage alerts as they come in, to assess the symptoms of the patient, and then really bring back to the provider only what's clinically necessary. And one thing that I'll add is that usually patient compliance with programs like this teeters around the 50 to 60% compliance rate. But this is one area where we stay hyper focused, and in particular, I think we've kind of figured this piece out. So we are proud to report that we have about a 90% patient compliance rate with the program. Next slide, please. So as you can imagine, we have a ton of data that flows back to us from all of our patients. And so, we use very sophisticated AI to help parse and really prioritize this data so that our skilled nurses stay focused on the patients who truly need that timely triage. They follow care management protocols. These can be customized at the practice level. So practices have a say in exactly what protocol they would want our team to use. We have a very comprehensive assessment that's then performed of the patient, and then patients are advised on appropriate next steps. And we only escalate these findings back to the practice when clinically necessary or when the practice or provider needs to intervene. Next slide, please. So our goal with alerts is always to minimize noise, to reduce any sort of alert fatigue for the provider, because again, we know, you're busy and you don't need one more thing sort of coming back to your inbox unless you actually need to act on it. Next slide, please. And so finally, this brings us just to the administrative piece of the program. So we do provide all appropriate notifications and documentation. It's all provided directly in your EHR, including patient progress reports. We are integrated with several systems already, but we continue to expand that EHR footprint as well. And anywhere that we're not already fully integrated, we manually add things in just so that, you as the provider and your care teams, you don't need to leave the EHR that you're used to working within. You can comfortably stay within that system. And then also on a monthly basis, we would email the qualified billing report directly to the billing team to make it easy for them to be able to drop the claims appropriately. Next slide, please. Oh, I think there's both animations there as well. So, just to recap, with the help of many physician friends and partners, we've built a program that is scalable. It's extremely customizable based on your preferences. And we have been able to demonstrate, improved health outcomes and high patient and provider satisfaction. So again, I thank you so much for allowing me to share a little bit more about what we do. My email address is listed there if you are interested in learning a little bit more, or like I said, if you reach out to Keith directly, he can connect us. But if there's any questions, I'd be happy to answer those.
One question.
Okay.
The question came in, how much will this add in cost to patient care, and how will that affect the ACO in general? Does it interfere with other home care programs? You able to hear that, or do we need to repeat it?
Alicia, were you able to hear the question?
I believe so. It sounded like there were several questions in there. So in terms of what the cost to the patient would be. Because it's a Medicare program, it would be, they may have their customary 20% copay, which is generally between $12 and $30 a month, just depending on the services rendered. If patients have secondary or supplemental insurance, that almost always takes care of their copay. But that would be the cost to the patient. I'm sorry, what was the next part of that question?
How can you predict, or what do you think the impact will be on the accountable care organization that we have, if that is a beneficiary that is attributed to that?
Yeah, so because we stay focused on only putting the high-risk patients on the program, that, the program is not about putting all patients on and driving cost up. It's really about selecting the high-risk patients who are already sort of high utilizers who are driving those costs up. It's about getting those patients onto the program and working with them to get their condition under control. By minimizing unnecessary ER visits and hospitalizations, we are able to reduce total cost of care that way. So the program is very much sort of rooted in value-based care. So we stay focused on that. There's always a balance between the fee for service and the value-based care, but the goal is always to, reduce that overall cost and not increase cost to ACOs, for example.
And the very last part of this question you may have addressed already is, if the patient already has some home care services involved, how does this layer on, or does this interfere with that?
So I don't think it would interfere with anything that the patient already has. I mean, we work very closely with chronic care management groups, alongside our program, and the way that we work that is just to, stay very well connected with those nurses in that program. But RPM, CCM, all of those codes are independent and can be, the patient can be enrolled in both programs. There's no, according to CMS, there's no restriction there.
I think that's it for the questions. Thank you, Alicia. I appreciate it.
Thank you so much.
Our final partner presenter this evening is Mindola. And here we go. So Mindola helps primary care practices meet the many challenges of behavioral health. And by that, I mean, not just identifying those that need the help, but also providing access to that help while offering some significant revenue opportunities to your practice. And Mindola does so with a model that doesn't put a big strain on you or your team. So it's my pleasure to introduce James Dold of Mindola to walk through a few slides and present to you what Mindola brings to the table. James?
Hey, Keith. You guys hear me all right?
Gotcha.
Fantastic. Next slide would be great. Next one. It's nice that we're going to actually hear some continuity and some themes between the vendors that the PA Clinical Networks has actually chosen to work with. So from Mindola's perspective, we're the national leader in the delivery of behavioral health services from the collaborative care perspective. We built our program learning how to manage the most complex patients with behavioral health needs in the community. And when we decided to launch collaborative care, it was a simple process for us of kind of backing off of the acuity tier and learning how to engage with patients in the mild to moderate category. But my question is really simple. Next slide, because I try to hit home. Right. So we'll get into the details here in a few minutes, but from a dollars perspective, there's about $3,000 per provider annually on a per patient basis. And we're seeing consistently between a 40 and 60% reduction in total cost of care across the board. In addition to that, and arguably as important, significant SDOH reduction from a burden perspective at the practice level, which leads to a happier practice, not just for the providers, which is of paramount importance, but also for the patients, because they have a resource now they can go to in real time and get solutions solved for in very fast order. But let's talk about the benefits really quickly. Next slide, please. We addressed the behavioral health needs for the practice as a whole, not just the ACO. We're available 24/7. So when a patient has a need in the behavioral health arena, they're not going to call the practice. They can call us, and we're available for them 24/7. After you make the referral, we're outreaching within 2 business days. There is no limit to the number of patients we can take because this is all virtually done. And if it's an older population, it works just as well over the phone as it does with a smartphone. We actually integrate really well with existing resources. And if you have other care management sources of opportunity within the ACO or within the practice, part of my job is to work with operations to streamline that process for everybody. And much as the other programs, whether I see the patient 2 times a month or 26 times a month, the patient only has a single copay on a monthly basis. So we have a very high engagement rate with our patients at the practice level because there's a lot of inherent value in the services that we offer. Next slide. Really quickly, the care team here is of paramount importance, and you heard this again with the RPM. The goal here is not to engage or interfere with the work that the provider does with the patient, but bolt onto the side of that relationship. Our virtual care manager will be doing the majority and all of that outreach and coordinating with the practice on an ongoing and as needed basis. We leverage all 3 of those opportunities in that peach bubble, our registry, our virtual psychiatrist, and our care management staff, to form a bubble around the patient and provide their behavioral health needs with not just resources, but actually solutions. And if they fall outside of that continuum of a mild to moderate and are more severely acute, I tell everybody the very same story. Don't overthink it. Refer all the patients you have a question about. Let us triage and evaluate them. If they're appropriate, we'll enroll them. If they're not, we'll hand them off. But if they're too acute, we're not going to throw them back unless they're, actively suicidal, which has an entirely different workflow. But we'll say, okay, you know what? James Dold is too acute for collaborative care, but we're going to enroll him and actively work in the community to find him resources that are a good fit. And while we're waiting for those appointments to become available, we'll keep working with him from a collaborative care perspective and try to keep him put together until we can get to that next level of resource. Next slide, please. Again, a consistent theme. The goal here is to be as simple as we can for the providers, because as you've heard, you got 1,000 things. I'm a huge advocate for primary care. Having built the network here in Boston with Tufts, providers have 1,000 things happening every day, every hour of the day, right? So it's easy. We use validated assessment tools. Our recommendations may or may not involve medications. And the goal here is to communicate back to the provider as quickly as possible, usually within 10 days of that referral coming out. Next slide. So to make it really simple, again, refer, review, write for the prescriptions as requested, and then submit the billing on a monthly basis. And what we see, which is similar to the other service line, about $40 or $50 per patient from a new coach perspective will stay with the practice. Next slide. So let's think about this at scale. I tell everybody the very same story. The behavioral health needs at the practice level run as high as 40% in a primary care practice and as high as 70% in a women's health practice. It's a daunting idea to get your head wrapped around. You shouldn't be referring 5 patients a month. You should be referring 25 or 30 patients a week if you can, because the impact is so great on your practice. So if we have 100 patients enrolled in this program active on an ongoing basis annually, there's about a $300 opportunity between 2 things. The net of the codes, which are $40 or $50 per patient per month. And we also see a 0.3 coding pickup on the behavioral health side of the coin, that when you have the opportunity to right size your population 4 times a year, you'll see about a $225 per month increase in the opportunity at the practice level, because you're clearly and accurately coding for these patients and their behavioral health challenges. As I mentioned earlier, Privia, one of our longer standing partners, is showing consistently across all of their markets a 40 to 60% reduction in cost of care, right? And so from an ACO perspective, yes, there is opportunity here from a cost perspective for these patients in your ACO, but if I can shave 40% off of the total cost of care for your most acute patients, our length of service is between 5 and 7 months. That's a significant uptick in terms of the revenue opportunity at the practice level. Next slide. And this is actual data from an ACO I've been working with in the Mid-Atlantic. And I was providing this to them on a monthly basis as to what does their panel of patients look like and where's the opportunity for them to get engaged. I tell everybody, I'm a behavioral health nurse by training, ER nurse after that. It can be as simple as any patient with 2 or more chronic conditions. The data is spectacular. Any patient with 2 or more chronic conditions is 3 to 5 times more likely to get depressed. And when they get depressed, your value or your expense to manage that patient goes up significantly. And so here we're looking at patients with 2 or more chronic conditions as a flag, and patients with depression or severe mental illness as a flag. And again, we can slice and dice the population any way you want us to work with you, but the opportunity from a coding perspective and from a net new revenue on this new codes that you'd be billing is significant. Next slide. Same practice, right? I did a really quick, non-scientific study, but I matched the top 10 chronic conditions, patients with depression and patients without depression. And what you see in that red box is the bottom is how much they're spending on the management of those patients with those chronic conditions after they get that depressive diagnosis tied to it. And the average is 276% more to manage those patients with those chronic conditions, in addition to a depressive diagnoses that are tied to it. And again, next slide would be great. And again, the goal here is to make it simple. This flows into your EMR on a per patient basis. It has the assessments we're working on with the patient, their progress to goal. On the right side of that document is the psychiatrist findings, his or her medication recommendations, the diagnostic recommendations. So you're seeing that coding pickup. And most importantly, bottom left, there's not a yellow box on this version, but the psychiatrist's direct email and cell phone, right? So I recognize writing for psych medication is outside of the scope or the wheelhouse for most primary care providers. It's a very uncomfortable space, at least initially. This allows 2 things. You can get your hands wrapped around the entire needs profile of the patient by leveraging a consulting psychiatrist. And every provider I've worked with in the 28 states we're doing this today, at the 90-day mark, when they've enrolled, a couple of dozen patients in a program like this, they wonder how they did it for so long without having real-time access to a consulting psychiatrist at the end of the phone or the end of an email thread. And I can stop there for questions or concerns or comments.
You need these, James?
Thanks,
No,
Jim.
we just wait for comments or questions. These are just bonus.
I don't know if we have any questions in the Q&A for behavioral health. If not, thanks, Keith, and thank you, Brilliant Care and Mindula, for your valuable services as well. We're coming down the home stretch, and I thank you for your attention tonight. We have certainly come a long way from our initial vision of the Pennsylvania Medical Society House of Delegates to our current reality. It is a marathon, but we're all facing in the same direction, and we're all going forward. As we emerge from our inception stage, we'll now build on our experience and success to further optimize the care and gain more recognition for the excellent care that you already provide. We are no longer newbies, and we have a common vision and are moving towards our greater success together. And with a common vision, we are not, as many characterize us like physicians and cats, unwilling and unable to come together to our goals. The success and tools that we heard about tonight are investments and reinvestments back into our network to better support your care and yield even greater recognition and better care going forward. As our quality director, Wendy York, noted, more emphasis will be placed on identifying those complex patients that need additional resources, such as Brilliant Care or Mindula. Our managers will work with your team to highlight gaps to help you prep for the most productive patient visit in the limited time that you have in your busy patient schedules. Together, we will work smarter, not harder, with pre-visit planning, and our data will guide us towards our next actionable steps. Allow me to recognize 2 more of our committees. Again, the committees are kind of our workhorse that we get things done, and again, are governed by you. Our Oversight Committee is chaired by Dr. Armstrong. Oversight Committee provides overall guidance with their finger on the pulse of where we are as a network and where we are going. The Contracting Committee is chaired by Dr. Ramanian, which reviews our quality contract arrangements and entertains new payers that we should consider going forward. We thank those committees and all of the committees and the members for your participation, and ask you to also consider joining if you do not already, especially our Quality Committee as one of the most important guides to drive success. And again, your leadership is our secret sauce and the key to our success. Likewise, in our PACN ACO, we will build on our experience and focus more on the high-risk patients by identifying those at risk and interfacing with your offices to make sure that they are seen and fully captured so that you can best direct their care and keep them healthy. Remember also that our valuable committees support our ACO, and we look forward to your participation. While we have much to celebrate in 2022, with bigger numbers and bigger achievements, we have much more ahead of us in 2023 and beyond. With you and our powerful network and our partners such as Curie, Mindula, and Brilliant Care, the future is indeed bright. We have a little more time, and thank you for your engagement tonight. You can enter any questions in the Q&A section on the bottom of the screen. Or if you think of a question after tonight, shoot us a message and we'll get you an answer. We are honored to be your resource. There was an earlier chat question about specialists in our PA clinical network, and this is a great question. And thank you for it. The majority of our members are primary care practices. And indeed, our value-based contracts at present are offered by insurance focus on primary care metrics. Last year, however, we ran a pilot project on diabetic retinal examinations with 2 of our ophthalmology specialty practices in our network. In addition to closing vision gaps on several diabetic patients, we learned that our diverse geography presents challenges for our patients, and where a specialist is located is almost as important as the specialty itself. Going forward, we're going to look for remote specialist opportunities to serve practices across the state, as well as focused areas. Of course, every practice, primary care or specialist, benefits from our network and our network partners, as mentioned this evening. In regards to data integration for specialists, integrating the diversity of DMRs, payer streams, and claims has been a mountain. Yes, we hope to have our specialists fully integrated as well, but first need to build on our primary care integration and success to expand thereafter. If you have any specific ideas about pilot applications for the network and your specialty, please let us know. As a small network, we can explore new and great ideas. That was a great question. Any other Q&A questions? Well, with that, I guess we'll conclude our evening. I want to thank you again for your time and most importantly, your engagement and your membership. Together, we are stronger. Good night. As Jason kindly offered, we can field some questions on venue now. You want to put them in the chat function if you can. If not, we'll move on to review some of the other services that Curie provides. Do we have any venue related questions for Jason? And again, if you think of other questions after this meeting, and again, if we don't get to your question tonight, because we do have a full agenda, we will respond to you individually and get back to you. And certainly we're always open to additional questions, and I'm sure we can get a hold of Jason and his expertise if there is something specific for that.